Good morning, everyone. My name is Mary Jane Apolonio, and I want to thank you for joining me on this evidence-based practice presentation. Healthcare systems are continually striving to deliver the safest, highest quality of care. By adopting evidence-based practice, we determine appropriate solutions for best outcomes. Our PICO question: how can a closed observation unit improve hospital throughput process in comparison to the medical surgical units, affect hospital length of stay within the next 6 months? This PICO question will hopefully answer the continued expectations of the Centers of Medicare and Medicaid Services, regulations, and compliance. At Shady Grove Medical Center, improvement projects among the clinical care teams continue to work on in its performance. Utilizing a closed observation unit will impact the success of a grounded throughput process that is critical to meeting the demands of the patient satisfaction and profitability. This presenter partnered with her organization to work on this project. Shady Grove Medical Center is a faith-based organization that aligns system processes in achieving its mission, vision, and values. With that said, this project will illustrate how Shady Grove Medical Center continually seek to determine and optimize healthcare performance by grounding an effective throughput process. So, with that said, this organization has its 6 pillars: people. Staff and all stakeholders will be engaged to coordinate care and processes. Quality and safety, along with patient experience. Quality and safety will be the timely delivery of care, and that is quality and safe care. That then impacts our patient experience. Happy patients will give positive surveys, and positive surveys gives us better reimbursement. Better reimbursement, as well as lowering the length of stay on this throughput process, will then impact our finance pillar. Our finance pillar, due to the good lowering of the length of stay in the process of our throughput, will then give us a better growth in a sense that our volume increases and we will be able to see more patients. As we see more patients in a grounded throughput process, we hope to be able to decrease conversion rates and decrease readmissions through our population health pillar. So, what did we do? We developed our work plan, and then we were able to adopt the Lean methodology of the DMAIC process. The Lean management model is one of the commonly used models in industrial areas. D for define. We describe the goal and the problems in the definition phase. We will define our project selection matrix, our project charter, and our corporate goal alignment. We will also look at our measurement plan and look at our line graph. And both this will be worked on together on a draft due date, and that has a specific final submission date. Then we will analyze. We will analyze by using a single case bore and putting it in a Pareto analysis graph. At that point, we will look at our value added and the non-value added variables. Then we will drill down to the 5 whys to look at the raw cost analysis by looking at the waste that are being identified. And we will eliminate those wastes before we implement our countermeasures, which will be our improved phase. We will look carefully to implement our action plan, and we will look at a post-improvement flow chart and looking at our line graph. Then we will look at our control phase, which will monitor the most significant variables that is effective, and we will identify the delays and bottlenecks involved when it's not effective. Hence, in our project description selection matrix, we were able to identify in our in our process that the RNs in the observation unit are challenged waiting for the emergency nurse to give them report once a patient is identified to be admitted in the observation unit. We look at the customers and the stakeholders, the impact of the accuracy, the cost, and the timeliness. And then we multiplied it with the performance graph, with the performance gap. We rated them from 1 to 5, 5 being the extreme and 1 being the lowest. We multiplied it together and then multiplied it by 1.5 if it was a yes, and 1 if it was a no. With that being said, the impact for a nurse not able to give report timely gives a performance gap that is really extreme, and we multiplied 5 times 5 to 25 times 1.5 is 37.5, and that bingo gives us the real variable that we can now look in our business case. In our project charter, we'll look who are in our business case, our objectives, our scope, our team members, and our schedule for compliance or completion. Our project name is to improve our interval from the bed assigned to the patient arrival on the observation unit in line with our PICO question. And our impact of the problem is delaying in getting the patients in the observation unit or 2C as a barrier to starting excellent care, increased length of stay, and it's impeding our patient experience. Our expected benefit is to be able to improve throughput time interval as measured by the time the bed is assigned to the time the patient arrives in the observation unit, or we call it the 2C bed. We then define our pillars of excellence of alignment. At Shady Grove Medical Center with their 6 pillars, we were able to identify most that we will impact patient experience, finance, quality, and safe care. We will prioritize how we transition this effectively by using our RISE's values of service and improving the time interval from the time the bed is assigned to the patient's arrival on the observation unit. Here's our measurement plan. Our measure of success is to truly look at our bed assigned time to the EDD part of the patient. Our target will be 45 minutes and our world class is 30 minutes. We will look at a downward trend. As we have noted our baseline of 63 minutes, the sum of the time between the bed is assigned to EDD part for all patients in the sample will be our numerator, and the number of patients in the sample will be our denominator. We will report this as an average time in minutes by looking at the data in our Cerner application. And here's our gap as we measured our baseline of 63 minutes, and we will target 45 minutes. 63 minutes from January, 64 in February, and 72 on March. We then gathered the data, and yes, the ED nurse not available for report occurred 13 times, which is the highest variable that we can look as our bottleneck in a smooth throughput process. We do not have control for this, but we have control for these other variables like waiting for results and the 2C or observation nurse not being able to get report. We put this in a Pareto analysis, and again, in the Pareto analysis, it's evident that the ED nurse not being able to get report is our bottleneck. And bingo, we were able to then look at and drill down in getting to the root cause analysis, the reasons of why, and then come down to be able to identify that this is truly a standard failure. A standard failure and not a people failure is a process failure. So we process every step of the way on how we can effectively, safely, and timely bring a patient from the ER to the observation unit. We look at all our value added and non-value added variables. And then here we go. Here's the waste. All our waste is the waiting time. So there was no room to be used to waste our time. And so what we did, we were able to go pick up our patients in the emergency department. Truly, the effectiveness and the feasibility of picking the patient multiplied by 5 and 5 as the highest or the best to be able to get the bottleneck with, we multiplied it by 1.5 for 1.5 for yes, and we overall scored it to 37.5. And here we go. As we went to pick up patients in the ED, we started it on April. And when we started it on April, all observation patients were picked up by the TUSI staff from the ED, and it also delivered safe quality care with timely bedside shift report. And here's our results. From 63 baseline, we went down to 22 minutes, which is our world-class score. Then we looked at our length of stay, and our length of stay decreased from 2 hours. From 23 hours, we went down to 21 hours. That is a huge step for grounding a throughput process in an observation unit. And this is where the med-surg lies. The med-surg units continue to be at 59 minutes for their bed assigned to the EDD part, as well as their length of stay continued to be at the high 40s, 47 minutes. So, we will continue the bed assigned and monitor 45 minutes, and we will continue to monthly get our data. Our impact is great patient experience, our financial impact, and staff engagement. Happy employees, happy customers. Teamwork is the key. Clear communication is imperative to coordinate timely care. Throughput time is truly measured when the bed is assigned to the time the patient departs in the ED. This ends my presentation. Let me know if you have any questions. Thank you for being with me on this presentation. Have a wonderful day.